Dear colleagues, my name is Sergey Avetisov. I am an academician of the Russian Academy of Sciences, professor, doctor of medical sciences, head of Department of Reconstructive Surgery of the anterior segment of the eye, and the head of Department of Ocular Pathology of the Research Institute of Eye Diseases. Today, I would like to share with you the results of a 2-year clinical study of myopia control with bifocal defocus-inducing soft contact lenses. A few words about the relevance of the issue of myopia. A distinctive feature of myopia is the potential for an increase in its degree. In other words, progression. Myopia progression can lead to changes in the ocular fundus because of axial elongation. In case of these changes, we are talking about the so-called complicated myopia. Progression of complicated myopia is one of the main causes of irreversible loss of vision. It must be noted that a number of studies noted that reducing the progression of myopia by 1 diopter reduces the risk of developing myopic maculopathy and open-angle glaucoma by 40 and 20% respectively. The term prevention or control of myopia progression implies a complex of therapeutic and preventive measures aimed at stabilizing progressive myopia and preventing complications. Modern methods of myopia control or interventions to control myopia can be divided into several groups: surgical treatment, device-assisted and functional treatment, pharmacological treatment, and, in the recent years, the use of optical correction means has become a very promising option for myopia management. Means of optical correction mostly rely on peripheral myopic defocus. According to the retinal peripheral defocus theory, at the level of the retina, there is a biochemical mechanism for regulating the axial length of the eye, which, in response to a change in the magnitude of the peripheral defocus, can affect the natural, genetically programmed growth of the eye. According to this theory, peripheral defocus accelerates the development of myopia, while myopic inhibits its development. It must be noted that the formation of myopic retinal defocus is accompanied by an increase in the thickness of the choroid. According to optical coherence tomography, after a 3-hour exposure to retinal myopic defocus, the choroid thickness in the subfoveal zone increased by 14 microns, and similar changes were found in the parafoveal area. Optical interventions for myopia control include orthokeratology lenses, specialty spectacle lenses of different designs, bifocal, progressive, and bifocal or multifocal soft contact lenses. According to the studies that became available in the recent years, multifocal contact lenses of various designs are able to slow myopia progression in children by 50 to 70%. The purpose of this presentation is to analyze the results of a 2-year clinical study of myopia control with bifocal defocus-inducing soft contact lenses. Speaking of materials and methods, 100 patients with mild to moderate bilateral myopia were enrolled. Inclusion criteria were as follows: spherical equivalent refraction within minus 0.25 to minus 5.75 diopters, meaning mild to moderate myopia, astigmatism and anisometropia no larger than 1 diopter, age from 8 to 16 years. The target coverage was at least 50% in the 8 to 10 years old age group, because this range is considered the most crucial when it comes to myopia progression. The study protocol was prepared in accordance with the ethical principles of the Declaration of Helsinki, and the informed written parental consent was obtained prior to study initiation. Exclusion criteria were presence of concomitant ocular pathology and use of other interventions for myopia control. There were 4 study groups formed, 2 main and 2 control groups. All groups were equable in the number of people. Patients of main groups were prescribed bifocal soft contact lenses. One group was comprised of patients with mild myopia, while the other of patients with moderate myopia. Patients of the control group were prescribed monofocal soft contact lenses. The group's division principle was the same. As to the characteristics of contact lenses used in the study, all lenses were intended for daytime use, were monthly disposable, made of hydrogel material, hydroxyfilcon B, and designed by the OK Vision company, based in Russia. In bifocal soft contact lenses, the 2.5mm center distance zone provided full correction, while the mid-peripheral zone formed the myopic retinal defocus due to an addition of +4 diopters. Why was that addition power chosen? According to a study in emmetropes, an addition of +3 or +4 diopters led to a significant change in peripheral refraction towards myopic defocus, so the myopic defocus was induced, while addition within the range of +2 diopters practically did not influence peripheral refraction compared to baseline. Specifics of fitting and using bifocal soft contact lenses. Optical power of the lens must provide distance visual acuity of 1 as per Snellen chart, or 20/20. Mobility must be within 0.5–0.75 mm range. Recommended wearing time is 12 hours a day, at least 6 days a week. Soft contact lenses should be replaced if refraction change is greater than 0.25 diopters and distance maximum visual acuity is decreased. Dynamic observation is required to assess the state of the cornea and soft contact lenses after a week, a month, and then every 3 months after fitting. Criteria and methods for assessing the results of monitoring myopia progression were as follows. Spherical equivalent refraction, assessed with automatic refractometry or a subjective cycloplegic refraction. Axial length, measured with optical biometry. And accommodation parameters. Positive relative accommodation, assessed with automatic refractometry. Amplitude of accommodation, assessed with automatic refractometry. Follow-up visits took place 3, 6, 12, 18, and 24 months after start of treatment. Results of the study. The first measured parameter was the change in spherical equivalent refraction. During treatment and observation, the increase in the spherical equivalent refraction in the main groups was significantly lower than in control groups, by 0.51 and 0.75 diopters after 12 months, and by 0.75 and 1.19 diopters after 24 months. All changes were statistically significant. The second parameter was change in the axial length. The increase in axial length in the main groups was significantly lower than in the control groups, by 0.13 and 0.13 mm after 12 months, by 1.01 and 1.05 mm after 24 months. Again, all changes were statistically significant. Regardless of the optical intervention, a significant increase in positive relative accommodation was noted after 24 months in all groups. However, changes in the amplitude of accommodation were more pronounced in the main group compared to the control group. In the main group, it increased by 6.41 and 7.62 after 12 months of treatment. Summing everything up, we can draw the following conclusion. Results of the study indicate the effectiveness of myopia management of mild and moderate degrees with bifocal soft contact lenses. Bifocal soft contact lenses simultaneously provide full correction in the center and induce a peripheral myopic retinal defocus due to an addition power of +4 diopters in the mid-peripheral zone. 12 and 24 months after the start of treatment, a stabilizing effect on the progression of mild and moderate myopia was noted in 72-73.5 and 54-79.5% of cases, respectively. Thank you very much for your attention.